Ladies and gentlemen, our next session will be on the International Colorectal Cancer Consortium. So I would like to introduce our next moderators. There are two moderators who really need no introduction. So I would like to introduce you to Professor Andrew Chan. He is a gastroenterologist, a professor of medicine at Harvard Medical School, and professor of immunology and infectious diseases at Harvard Thi Hanh Nhu School of Public Health, and the chief of the Clinical and Translational Epidemiology Unit at Massachusetts General Hospital. And the other moderator is Professor Ratha-korn Vilaichone. He is the professor of medicine at the Gastroenterology Unit at Thammasat University, and he is the chief at the Center of Excellence in Digestive Diseases and the chief of the FMT program at Thammasat University, Thailand.
So thank you so much for the nice introductions. Very first, we go to the first speakers. First speaker is Professor Andrew Chan. As the moderator say, he is a professor of medicine in Harvard Medical School. Professor Chan gonna talk about the colon cancers from epidemiology to prevention. Please welcome Professor Chan.
Good morning, and thank you again for this wonderful opportunity to speak here today and to be invited to this meeting. It's been a terrific opportunity to connect with friends and meet new colleagues. What I'd like to do today is discuss the paradigm that we've developed for colorectal cancer prevention, which is to try to understand more about the epidemiology of the disease to establish opportunities for preventive interventions. In particular, what I'd like to focus on today is a troubling trend that we're seeing in the United States and now seeing across more than 18 countries around the world, in which the age of diagnosis of people with colorectal cancer has been shifting to much younger ages. And we're seeing many, many more patients in our clinics now that are at the prime of their life developing this very terrible disease. So, to give you a snapshot of what's happening in the United States, we know there's a rising incidence of cancer overall in the US across many different organ sites. But in particular, there has been a rise in the development of colorectal cancer among younger individuals. And if you look at people who are less than age 50, we're seeing that there's been about a 15% increase in the incidence of early onset cases, people younger than 50, if you compare individuals over the 2 decades of 2010 through 2019. And we're seeing that this has been something that started in the 1990s. So as you can see from this curve, individuals that were younger than 50 that developed colon cancer began to steadily rise among both men and women. And this has been documented to be what we call a birth cohort effect. So people that were born in the decades after 1960 in particular were facing a much higher relative risk of colorectal cancer compared to people that were born before 1960. It's now become an epidemic in the United States to the point at which it's become the leading cause of cancer death among men younger than 50. So as you can see here, again, with these time trends, that lung and bronchus cancer has been steadily declining since we've had more efforts to curb smoking in the United States, but colorectal cancer has steadily risen. So now, in 2020, the leading cause of cancer death in people younger than 50 among men in the United States is due to colorectal cancer, which is really quite stunning. In women, also, colorectal cancer, seen here in the blue, is rising, and it's become also the second leading, will become also the second leading cause of cancer death as breast cancer starts to decline. This is not just an issue in the United States. There is now a global trend. This is an estimate that was done across the world, which showed that there's about a 24% increase incidence of colorectal cancer in people younger than 50. And this has been noted across different cancer types, but most striking has been the increase in colorectal cancer. This increase has been noted in more than 18 countries, and these include countries here in the Asian region. So if you see this bar graph, what we see across the countries on the left are the rate per 100,000 individuals. The countries that have red bars here are those countries that are seeing increase on people younger than 50. And at the top of the list is Korea. They've been seeing the most sustained increases in early onset disease across the world, followed by Australia and the US. Japan continues to have a high incidence of colorectal cancer, although it's been relatively flat recently and not rising in the same way as it has in Korea, which is obviously very close to Japan. So there is some geographic heterogeneity. And you also see increases across different countries in Europe, including Spain and the UK. And then as you see down into this area, in particular Thailand, there's also been a notable increase in the percentage of cases in people younger than 50. So this has become really a global issue, first noted in the US, but now being seen across different countries, including countries here in Asia. So why do we think this rapid increase is occurring? Well, our group at Harvard and Mass General have been really focused on understanding epidemiological risk factors for colorectal cancer among specifically younger individuals. And over the last decade or so, we've been able to identify key risk factors that seem to be operating in young people. That includes obesity, metabolic comorbid conditions like diabetes and metabolic syndrome. There's also been an association with fatty liver disease and early onset colorectal cancer, sedentary behavior. Drinking alcohol has also been linked with early onset cancer, in particular, drinking in a certain pattern that younger people are now increasingly doing, which is drinking without meals, and binge drinking is particularly risky. There's also been studies that we've done that have shown that birth by C-section may be associated with early onset colon cancer, which may be related to differences in the microbiome among young individuals who are born by C-section as opposed to vaginal birth. We've also demonstrated an association with the microbiome, specifically individuals that have a microbiome for which there is a large proportion of sulfur-reducing bacteria have a higher risk of young onset colon cancer. There's been data that we've also shown that sugar-sweetened beverages, drinking sugar-sweetened soda and juices is associated with early onset disease, as well as poor diet quality. So across these different risk factors, we recognize as well that these are risk factors that have been established in older adults, and they seem to be also very important in younger adults. I do want to focus a little bit on obesity in particular, because that's been the most robust association that we've shown in our studies and in studies that others have done. We know obesity has been linked to cancer broadly, and there has been demonstrations of the link between obesity and cancer in 5 to 13 different types of cancer. The IARC working group in France put together an international team to look at this question and identified these cancer types as being associated with obesity. And that includes, in particular, GI cancers like esophageal adenocarcinoma, gastric cardiac cancer, and colon and rectal cancer, liver cancer, gallbladder, and pancreas. So across the GI tract, we know that obesity is an important risk factor. How do we think about this in particular with early onset disease? Well, we also have to not only think about obesity as a risk factor at the time of diagnosis, but also obesity throughout the life course. And that may be underpinning why we're seeing a rapid increase in cases in young individuals, because now more and more we're seeing that there is obesity occurring throughout the life course, in particular in early adulthood and childhood. But there's also emerging research that potentially there are potential influences of obesity even earlier in life, for example, in the newborn period or even maternal obesity. And there's rapidly growing literature around the fact that maternal obesity itself may also be a risk factor for early onset cancer in offspring, which is a very interesting concept. So the question becomes, is there a critical time window in which exposure to obesity and or metabolic disturbances are most likely to result in risk of developing cancer at an earlier age? And how much also is the obesity epidemic in countries like the US, but also obesity which is rising across the world, how much is that actually contributing to the rising incidence of early onset colon cancer? Is it responsible for a large proportion of the increase we're seeing or a relatively small proportion? That's something that we need to investigate more fully. And also the question becomes, how do we intervene on this if this is one of the causes? How do we actually reduce the burden of obesity in the United States and also across the world? We've been also interested in studying novel risk factors. As I mentioned, the risk factors that we've identified for early onset colorectal cancer have also been identified to be risk factors in older cases. But are there novel risk factors in particular in young individuals? And so we've developed now this concept of the exposome, which is environmental, non-genetic drivers of health and disease across a given person, across someone's life course in a given individual. And this kind of exposome can be from the environment, but also can manifest itself internally through changes, for example, in someone's epigenome, or also someone's proteome or transcriptome. And these are all things that may influence the risk of disease. And this will lend itself to a functional exposome. But this functional exposome is something that potentially we can characterize through some molecular analyses to understand what are potential exposures that led to that exposome. So let me give you an example of how this is potentially applicable to colorectal cancer. There's been a lot of work done in the field of colorectal cancer to identify mutational signatures from whole genome sequencing data. So there's been, for example, an effort in the United States to look across different cancers at the potential mutational landscape of these cancers. And in colorectal cancer specifically, there have been studies that have been allowing us to classify certain mutational patterns that are predominant across different tumors. And in particular, there has been identification of mutational patterns that are more prevalent in younger people compared to older people. One of these mutational patterns is a specific signature called SBS88, which is a signature that's also associated with the exposure to colobactin. Colobactin is a toxin that's released by PKS positive E. coli. So a microbiome product of a toxin that can have genotoxicity and mutational events in colon tissue that can be detected by sequence data. And so we're seeing that in the literature from a group that has looked at this most closely in the UK and the United States, that there is a higher prevalence of this colobactin signature in individuals with young onset cancer, which suggests a potential role of colobactin specifically in early onset colon cancer. We also know that we can use molecular sequence data to identify other types of microbial signatures that can be used to infer risk factors. There's been work in specifically understanding the potential differences in the microbiome of people with colon cancer compared to without, and these microbiome signatures can be in turn linked to other exposures. And there has been work from other groups to identify a manually curated group of microbial signatures from metagenomic data to infer exposures of various kinds. Another approach is to use non-targeted small molecule profiling in the blood through liquid chromatography mass spectroscopy. And we can use this kind of technology to identify different chemicals that people have been exposed to, and some of these are known chemicals that can be potentially identified as risk factors for early onset colorectal cancer. And so as we heard yesterday from Dr. Lee about potentially exposures to things like microplastics, this represents a potential ability for us to identify exposure to microplastics as a risk factor for early onset colon cancer. So what is it that we can do to prevent and reduce the burden of early onset colorectal cancer? Well, one of the keys is to really focus on primary prevention. So if we identify risk factors for early onset cancer, Can we try to reverse those risk factors through lifestyle modification? And also using molecular prevention options, for example, the use of non-steroidal anti-inflammatory drugs or aspirin, which have been shown to reduce risk of cancer, may be a way to molecularly target the disease. We also have to think about the possibility of expanding early detection and screening programs in parts of the world where that is an option. So in the United States, colorectal cancer screening has actually been recommended to start at an earlier age than in the past. So for the last several years, we've begun screening our population at the age of 45 years as opposed to 50 years. Of course, that's not an option in many parts of the world, but it is an option potentially in some countries. And finally, we have to think about survivorship. Just to repeat again, the clear disparities that people face when they develop early onset cancer is quite different than older individuals. We know, for example, that people are getting this disease when they're at the prime of their life, both in terms of their career and also their personal lives. And so many of these are young parents or trying to have children or taking care of older parents. So developing cancer at that age can be devastating to multiple generations. So we really need to think urgently about what we can do to really effectively and equitably reduce the cancer burden in younger populations. So to address this, we've developed the first of its kind international team to deal with this issue and attack it from a research perspective. This is a new grant that we received from the Cancer Grand Challenges Program that's supported by the National Cancer Institute in the United States and Cancer Research UK to examine pathways, risk factors, and molecules to prevent early onset colorectal cancer. I'm one of the leads, and my co-lead is Dr. Yin Kao, who is one of my former trainees at Washington University in St. Louis. We've assembled an international team across different countries. We have partners in the UK, India, Europe, and specifically France and Italy, who all have different areas of expertise to focus their perspectives on this very difficult problem. And our overarching goal is to really advance correlation to causation for actionable prevention. Specifically, our first objective is to identify lifelong established and novel risk factors for colon cancer. And this will be achieved through collecting data from diverse cohorts across the globe. This, in turn, will allow us to use biospecimens collected from these cohorts to do some chemical and functional profiling to infer, again, the exposome. And then we hope to be able to use this to then translate into life course animal models and in vitro human models to understand what risk factors are actually cause and effect as opposed to simply association. This hopefully will then lead to the ability for us to design molecularly targeted trials. And this will be something that can lead to precision trials that can be used to prevent the disease in young populations through precision prevention strategies. By doing this, our goal is to really ascend the causal pyramid to really advance correlation all the way up to prevention. And so this will be an opportunity for us to come together as a global community to really deal with this problem. We have 4 work packages. One, again, is to assemble global cohorts, including cohorts in Asia and Europe. We also want to develop an ability to molecularly profile specimens from these cohorts in our second work package. This will also be used to correlate with our third work package, which is around animal models of disease, and our final work package is around our precision prevention studies. So in conclusion, there is clearly a rising incidence of early onset colorectal cancer across the globe, including several countries in the Asian community. There are several potential risk factors that are driving this trend. For example, obesity and certain dietary factors that have become more prevalent in younger generations appears to be very important. But we also have to think deeply about new risk factors. We think that there probably are other risk factors that have yet to be identified. And we need to use novel methods to identify these factors, including tumor mutational profiling and also non-targeted analysis of blood specimens. And we need to really do this urgently across the world because we have a huge rising cancer burden in younger populations. I'd like to thank all of the individuals in our group that have contributed to this research, as well as our treasured collaborators and also the individuals that have been supporting our research. Thank you.
Thank you so much, Andy. And I think that we have a little bit of time for a few questions. So for the very first, Andy, you mentioned that right now we have more cases of the early onset of colon cancers, not only in the US, but also in many Asian countries. Could you please summarize what is the major difference in terms of pathogenesis and the cause between the early onset and the late onset of colon cancers?
Yeah, so that's, I think, the major question in the field is there something different that's driving this early onset trend compared to the older onset disease? Clearly, the evidence shows that risk factors that are driving cases in older adults are actually very important in younger people too. And so it could be the changes in the level of exposure to those risk factors in young people that are driving some of the increase. So we know, for example, that obesity is rapidly rising in the US, and it's in particular rising in childhood. So that is definitely a driver of some of the increase in incidence. But it's not the complete story, so that's where we need to do more work on identifying new factors, in particular environmental risk factors, and that's where the field is needing to go, because that's a very big challenge. A lot of cohorts are not collecting data on important things like new environmental factors, so we can't rely on just questionnaires or things like that. We need to have novel methods like molecular profiling of the blood or the tumors, which will allow us to infer exposome signatures.
Thank you so much. So we're going to move to the next speakers.
Is Dr. Arti Wongcha-um. He's a clinical instructor at Thammasat University here in Bangkok.
So thank you, Professor Chan, for the introduction. So my talk today is on the current updates and future perspectives of colorectal cancer in Thailand. So according to the World Health Organization statistics in 2022, colon cancer is one of the leading cancers in terms of incidence. In males, it is the third most highest in incidence after liver and lung cancer, and in females, it is the second highest, and in both sexes, it's the fourth highest after liver, lung, and breast. And as Professor Andrew Chan mentioned in his talk, that there has been an increase in incidence of young onset colon cancer in population under 50 years old, and that's because of industrialization, increased consumption of Western diet and processed food that has been partly responsible for the increasing incidence in the young. And I would divide the aspects of colorectal cancer management into four main aspects. So primary prevention, the second is screening, third is curative, and fourth is palliative. And ideally, we would like to tackle colon cancer at the primary prevention, screening, and curative. And I argue that for primary prevention and screening, it will be more cost-effective than to tackle it in the curative stage, because surgery is more expensive. So the goal is to reduce the incidence and mortality from colorectal cancer. So what do I mean by primary prevention? So primary prevention is reducing modifiable risk factors that increase the risk of colon cancer, such as reducing smoking, processed meat, alcohol intake, red meat, and increased intake of vegetables and fruits, and reduce body fat and obesity, and increase intake of protective factors such as whole grains, dietary fibers, fish intake, certain vitamins, calcium supplements. But there are always some factors that can't be modified, such as genetics, family history, and male gender have increased risk of colon cancer compared to female, as well as having certain conditions such as diabetes and inflammatory bowel disease and ethnicity. So, according to the latest survey that was carried out to participants globally, participants were asked, do they feel there is enough information readily available about colon cancer? And the Thai participants, 58% of the Thai participants said they feel they don't have access to information about colon cancer, compared to 47% globally. And around 58% of eligible Thais have never had colorectal cancer screening, compared to the global average of 49%. So clearly we need to do more as a nation to increase education and awareness among the population, so that they can know what risk factors they need to reduce, and they need to go and seek colorectal cancer screening. So how does screening work in Thailand? So in response to increasing incidence of colorectal cancer, the Thai government announced the National Colorectal Cancer Screening Program. Among 70 million Thai population, 14 million are eligible and require screening. But there are only approximately 1,000 endoscopists available in the whole country. So clearly the population-based one-step colonoscopy program as a primary screening method is not feasible. So we require a two-step approach using one-time fecal immunochemical test or FIT test, which prioritizes and filters out patients for colonoscopy. So there was a pilot study done in the Lampang province in 2014, which enrolled over 100,000 people. They were invited to take a FIT test, and those who were positive underwent colonoscopy, and a good number of advanced polyps and colorectal cancer were detected. So after this successful pilot study, an official nationwide Thailand colorectal cancer screening program was launched in October 2017, using a one-time FIT with an initial cutoff of 100 nanograms per mil. The problem is that Thailand only has 1,000 GI endoscopists, and the calculated number of colonoscopies for asymptomatic participants with positive FIT results in Thailand would be 1.2 million per year. Based on the positive rate of FIT in asymptomatic patients estimated to be around 12%. Our healthcare system can only handle less than 200,000 colonoscopies per year, and that would require an estimated time of 8 to 12 years to screen the target population. So the cutoff was later increased to 150 nanograms per mil, because it offers both a high positive and negative predictive values for advanced neoplasia detection and reduce colonoscopy workload without increasing the rate of missed colorectal cancer. But what is the problem with that? Because after the recommendation to increase the cutoff value, some experts raised concerns that there is a risk of missing significant lesions in some patients. So in 2017, another multi-center prospective trial was initiated to evaluate FIT diagnostic performance at different cutoff levels in high risk versus average risk populations. And they used the Asia Pacific Colorectal Screening Score, which includes factors such as gender, age, smoking, family history of colon cancer, to determine who are high risk. And they found that at the cutoff of 25 nanograms per mil for high-risk patients and 150 for average-risk patients could maintain the sensitivity of the FIT test at around 80%. This study is still ongoing. So what is the incidence of the stages of colon cancer being diagnosed in Thailand? So it is being diagnosed way too late, because because just under 40% of the new diagnoses are being diagnosed at stage 3 or 4. And that's when you already have nodal and or distant metastases. And this is due to lack of organized population screening and lack of public health awareness. Only less than 20% are being diagnosed at stage 2 and less than 10% are being diagnosed at stage 1. Ideally, nationally, we need to increase the diagnosis rate in stage 1 and stage 2 rather than 3 and 4. Surgery waiting time in Thailand is also another problem. Surgery is the mainstay of treatment in curative treatment for colon cancer. It is estimated that we have one general surgeon to 35,000 individuals and 70 board-certified colorectal surgeons to Thailand's population of 70 million. So more than 1 in 4 cancer patients are waiting more than 1 month for surgery, which is not an acceptable waiting time. So in the last decade, there has been a shift to laparoscopic surgery to treat colon cancer over the open approach in cases where possible. Studies have shown comparable survival rate between the laparoscopic versus open approach. And the benefits of laparoscopic approach is that there is less recovery time, lower risk of infection, smaller scars, less pain and discomfort after surgery, and shorter hospital stay. And if you expand that to the nationwide level, that will free up the resources more quickly to deal with more cancer patients by having patients admitted for a shorter duration of time. However, there has been a slow growth of minimally invasive surgery for colorectal cancer in Thailand. And if you look at the figures comparing the percentage of minimally invasive surgery in major centers in Thailand, comparing between 2017 and 2018, in some centers it's actually gone down, and in other centers it's only the percentage has gone up a bit, and this is due to lack of well-trained laparoscopic surgeons, long learning curve, unsuitable cases for laparoscopic approach, such as those with bulky tumor or locally advanced cancer. There's suboptimal laparoscopic equipment and absence of reimbursement for some laparoscopic instruments. So what do we have to do nationally? So the Ministry of Public Health and the National Institute of Thailand are paying more attention to primary and secondary prevention to control colorectal cancer, as they are more cost-effective than having to deal with it through surgery. So therefore, we need to increase awareness and capacity for fit testing and screening colonoscopies in asymptomatic average risk population. The government has established another 2 surgical programs following the national-wide screening program. So one platform being one-day surgery in January 2018, and the second platform being the minimally invasive surgery for starting in January 2020. The ministry aims to set up at least 1 healthcare unit with complete one-day surgery and minimally invasive surgery platforms in each of the 13 regions of Thailand. So in conclusion, the incidence of colorectal cancer in Thailand has continued to increase in both sexes, and it's also being diagnosed at a more younger age as well. So the national health policies are needed with great focus on primary and secondary prevention. The Ministry of Public Health launched a population-based colorectal screening program in 2017, requiring 2 steps. So the initial step being the fit tests, and those who have positive fit tests then go on to have a colonoscopy. Additional adjustments may be required for fit cutoff value, and clinical risk stratification may be needed to stratify those that you have to prioritize for colonoscopy in order to reduce the colonoscopy workload. The number of trained endoscopists have to increase to have an effective screening program, and the trained colorectal surgeons are needed to increase to avoid delay in curative surgery. with the ultimate goal being to reduce the incidence of colon cancer and colon cancer-related mortality. Thank you very much.
So in Thailand, we have a screening for the colon cancers in the age more than 50 years. But right now, we have more and more cases of the colon cancers in the early onsets. Do you have any suggestion that how to improve to just like the screening to get more cases of the early onset of colon cancers for better management?
Yes, so we have increased colon cancer in the young, and as I mentioned, the most cost-effective way would be to educate the population to learn what signs and symptoms to look out for, and to reduce the risk factors that may increase the risk of colon cancer, and also encourage more people to go out there, when they reach 50 or even younger, to go out and have fit tests, and if positive, to have a colonoscopy.
Arti, very nicely presented as ever. I'm not sure that I agree with you that it's simply a matter of education and awareness of colorectal cancer, because in that survey you showed, which there was, just look at the awareness of colorectal cancer in Saudi Arabia. It was much higher than in Thailand, but the take-up rate for colorectal cancer screening was barely 30%. And what I infer from that is that it's not just about increasing awareness, it's translating that awareness into practice so that people actually have a screening procedure. That's just a general comment.
Yes.
The other is not meant to be political, but I'm very struck about your figures of lack of capacity, and empathize with that, and horrors that you might have to wait more than a month for surgery in Thailand. I wouldn't dare say what the waiting time for surgery is in the UK. But you have captured, Thailand has captured the international medical market. Has anybody looked at total medical and surgical capacity in Thailand compared to that which is available for the Thai population? And is there any discussion at a sort of strategic level about whether that capacity, which serves the international medical tourists and people, might be focused in part on the Thai population?
Thank you very much, Professor Travis. So in response to your first question, I agree that it may not be enough in just education purely to increase the colon cancer detection and to reduce the incidence. But I think it will help a long way in terms of by increasing awareness. But also, as I mentioned in my talk, there's a 70 million Thai population, and simply not enough resources to do the colonoscopy for the 14 million right now that are eligible to.
Yeah, but it's a related point about the fact that lots of colonoscopies of those are actually focusing their activity on visitors, not the Thai population. I don't want to press that, but it seems to me that the discussion might be that a certain amount of activity should be for the benefit of the Thai population rather than purely for private practice for visitors.
Yeah, yes, I certainly agree. So I mean, the figures that are given, I think, is based on the Thai population as a whole, because as you know, we have a private sector in in Thailand, and in the private sector, people who have insurance or willing to pay, they can, if they're worried about having colon cancer, they can actually go and get a colonoscopy straight away without needing a fit test. So certainly, as you're aware, there's a private sector and the public sector in Thailand, but I think these figures is just for the public sector as a whole.
Yeah. Okay. Vilaichone,
Simon,
yes.
I would like to respond to
okay,
your
yes.
challenging question.
Yeah.
And, we have a lot of medical tourism. You and I deal with Middle Eastern patients, and they just do upon request. Because they're quite aware, and even young people, they come and request colonoscopy screening, with or without symptom, maybe with a bit of symptom. And I don't think Thailand focus on this market right now, and it doesn't have a problem with the policy or the way to do it and how. But this all private sector. And I know in UK system is different as well.
Yeah, I'm certainly not advocating a sort of socialist left-wing UK approach to public health care at all. But I was just very struck. You have been very successful in achieving the totality of provision, though. You feel that there might be a better balance, and that obviously takes careful discussion, because if we're all doing just on-demand private colonoscopy and so on, where there's a large unmet need in the population, you can't help feeling that maybe doing a certain proportion who are for the population at large might actually release that capacity if they're going to get a license to practice privately.
Yeah, I think the Thai government have done enough. That's what they can do. I'm sure they'll do more in the future, but private sector is totally different. One can do whatever.
But you can regulate the private sector a bit, I suppose. And it is a political point. I grant you that, and so
yes.
I will stop there. But I think it merits.
Professor Travis, and I would like to ask you, what is the screening program like in the UK? Can you share
it's
with
actually
us?
very efficient. There are some things in the NHS which work very rapidly and very well, and you get, once you're over the age of 55 now, you get through the post a fit test, and you do that, and if it's positive, then you are rapidly tracked to colonoscopy within 2 weeks, and you have a procedure performed by an accredited bowel cancer screening colonoscopist, not just somebody, a gastroenterologist, who say they can do colonoscopy. So actually, that side works. There's then a delay whilst they get appropriate surgery, I'm afraid.
That's
Thank you very much.
the good discussions. For long story short, I think right now in Thailand, the policies to do colonoscopy is quite shorter terms. Mostly going to wait for 1 or 2 weeks, and we have a good referral service for the patients wait for the treatment for the surgeries. Maybe just refer to the centers in Bangkok or in many parts of the center in different regions of Thailand. The times for waiting might be less than a couple of weeks. So because of the time, we have to move to the next speakers. Next speakers is Dr. Amal Arifi Hidayat from University of Alanga. He's going to let us know more about the clinical and current situations of colon cancers in Indonesia. Dr. Amal, please.
Thank you for your introduction, Professor Ratha-korn. Good morning, my esteemed college. My name is Amal, and today I represent Erlangga University and Indonesian Pylori and Microbiota Study Group. It is an honor to be here and to have the opportunity to share our work with such a distinguished group of experts. At this moment, I would like to talk about current situation of colorectal cancer in Indonesia, as well as potential research opportunities and future directions. The latest global study reported that colorectal cancer remains an important non-communicable disease in Indonesia. Currently, CRC is the third most prevalent cancer in the nation. With a rate of 8%, CRC has the fourth highest incidence rate of all cancers. CRC is also documented as one of the 5 leading causes of cancer-related death in this country. With our huge national population, The mortality rate from CRC is almost 20,000 deaths every 5 years. According to data from Indonesia's 4 most populated cities, CRC is most frequently diagnosed among individuals aged 50 to 60. The most concerning point is that the overall CRC incidence in Indonesia keeps on rising every year, as demonstrated in a previous study conducted at Jakarta. Interestingly, this only consistently applies in the colon cancer but not in rectal cancer. The incidence rate of right-sided colon cancer is also increasing, especially in age over than 50 years. Based on the sidedness of primary tumors, left-sided CRC was the common, followed by rectal cancer. An unusual epidemiologic finding was also discovered in a separate local research in a different city, namely Yogyakarta. Despite an overall increase in incidence annually, they discovered that this only applies to people over the age of 50, not those under the age of 50. In contrast with CRC situation in Jakarta, the trend of both colon and rectal cancer in Yogyakarta is increasing. With more than 1,000 different ethnic backgrounds, Indonesia is a country whose genetic profile of CRC may be unique. The number of genetic studies on Indonesian CRC is still scarce, diverse in methodology, and involve only a small number of participants. The very first genetic study was conducted in 2 cities located on separate islands, namely Banten and Tarakan. The study found that the APC gene expression is significantly lower in CRC patients than in controls. Both hereditary and non-hereditary CRC patients express APC gene in unequal rate, indicating classic adenoma sequence pathway is still dominant. Another investigation conducted in 3 different cities, Jakarta, Bandung, and Makassar, identified an alteration in the expression of the mismatch machinery gene. MLH1 was shown to be downregulated in more than 80% of Indonesian CRC patients, while MSH2 was only positive in half of them. A small study conducted in Bali found a 22% mutation rate for KRAS and 11% for BRAF. All these findings suggest that both adenocarcinoma sequence and serrated polyp pathway is important in the molecular pathogenesis of Indonesian CRC. A genomic profile study using next-generation sequencing revealed that all Indonesian CRC patients had genetic mutation in the chromosomal instability pathway. This indicates that CRC may actually be preventable in Indonesia, as it typically requires 7 to 10 years to develop cancer from precancerous lesions. In contrast to Western countries, the incidence of CRC in Indonesia is rising exponentially. This is owing in part to the lack of national CRC screening program in comparison to developed countries such as UK or US. Indonesia provides a tremendous opportunity for innovative colorectal cancer research. With rising incidence and unique genetic and environmental factors, Indonesia offers a rich landscape for innovative studies. Collaborative efforts can bridge resource gaps, fostering advancements and benefit both local population and global cancer research. Our study group has recently conducted an investigation on Indonesian CRC that has not yet been published. Indonesia has a population of more than 250 million people living on thousands of islands. However, we have only around 300 hospitals with endoscopy system, and most are located on the Myint Island, Java. On top of that, the number of imaging modalities available for the baseline evaluation of distant tumor extension, such as CT or MRI, are also limited and unable to meet the national demand. The diagnosis process is delayed while the progression of disease is still ongoing, as the queue for CT or MRI at our hospital, for example, may last for up to 4 months just for CT or MRI. To deal with this kind of situation, we conducted a study that investigated multiple biomarkers that may play a role in stratifying priority for referral system. Patients who underwent a colonoscopy and had their CRC diagnosis confirmed by pathology were involved. All subjects performed an extensive examination, including abdominal CT or MRI, and additional imaging as indicated by clinical suspicion of metastasis. The biopsy samples obtained from colonoscopy were fixated using liquid nitrogen, and formaldehyde prior analysis with quantitative RT-PCR for microRNA 2124 and 145. We also prepare paraffin blocks for immunohistochemistry analysis for 5 different tissue markers, which consist of KRAS, BRAF, TP53, COL3A1, and SOCS2. The age of subjects was 56 years on average, and 46% of them were male. The Javanese was the predominant ethnicity at 74%, and 15% of the cases have a first-degree relatives of CRC without a known germline mutation. The primary tumor were located on the left side in 80% of subjects, whereas around 20% were located on the right side. Our study population primarily consisted of advanced CRC patients with 47% exhibiting regional metastasis and 41% presenting distant metastasis. The analysis indicated that the expression level of TP53 and microRNA-24 had an inverse correlation with the progression of clinical staging, whereas microRNA-21 as well as the ratio of microRNA-21-24 had a positive correlation. It is important to note that the expression of TP53 was found to be absent in the majority of subjects with distant metastasis or stage 4. Further sub-analysis based on tumor location, which is not shown here, revealed that the negative correlation of TP53 was only applicable to the left side CRC and not the right side. Subjects with distant metastasis have a lower level of expression of TP53 compared to those without. This result indirectly indicates a downregulation phenomenon of the TP53 gene in metastatic CRC patients. We observed that localized CRC had significantly lower expression of microRNA-21 as compared to those with distant metastasis. In contrast, localized CRC demonstrated higher expression of microRNA-24. This finding indicated that the expression of microRNA was altered in metastatic CRC, specifically the upregulation of microRNA-21 and the downregulation of microRNA-24. In turn, those with distant metastasis showed a higher ratio of microRNA-21-24. We then performed an ROC analysis of the microRNA to evaluate whether it could improve the accuracy of their diagnostic value predictions. It was found that the ratio of microRNA-21-24 has the best diagnostic accuracy to predict metastasis with an AUC of 0.83, outperforming microRNA-21 and 24 as a single markers. Using a cutoff value around 20, microRNA-21-24 ratio showed a positive predictive value of 94%, suggesting its utility as biomarker for metastasis. Despite failing to demonstrate any statistical significant association with clinical indicators, BRAF, KRAS, COL3A1, and SOCS2 were found to be directly correlated with TP53 expression itself. The negative correlation of TP53 with clinical stage progression support the hypothesis that the loss of TP53 occurs at a later stage in classical adenoma sequence. The rate of inactivating mutation in TP53 was relatively low in precancerous lesions, while a higher prevalence was observed in cases of invasive cancers. Since the expression of TP53 is relatively high in patients with early stage cancer, our results indicate that most CRC patients in Indonesia do not originate from IBD. Another literature said that in colitis associated CRC, the loss of heterozygosity for the TP53 gene occurs as an early event in the pathogenesis of colorectal cancer. In 2015, the Colorectal Cancer Subtyping Consortium unified all previous molecular classification into a single system called Consensus Molecular Subtype, or CMS. From this study, we do know that Indonesian CRC patient is mostly left-sided and demonstrate a late loss of TP50 gene. These two characteristics were consistent with those of CMS2, commonly known as the canonical subtype of CRC. And among all 4 molecular subtypes, CMS2 demonstrates the most favorable prognosis. And this study indicates that Indonesian CRC patient may respond well to fluoropyrimidine-based chemotherapy such as Volvox or Volviri, as well as anti-EGFR therapies. The latest ESMO guideline of CRC in 2020 recommends a comprehensive assessment of distant tumor extension once the diagnosis of CRC is confirmed by pathology. The extensive workup includes CT or MRI, and because this imaging technology is not widely available in our country, the ratio of microRNA 2124 has the potential to be used as a biomarker to identify CRC patients which were high risk of metastasis. This is absolutely crucial for lowering the demand on our referral system for extensive imaging tests. In conclusion, our study highlights that P53 microRNA 21 and 24 expression was found to be altered in more advanced clinical stage and distant metastasis, indicating its important role in CRC aggressive nature. And the ratio of microRNA 21-24 has shown a potential as a biomarker for identifying patients at high risk of metastasis and can be used to determine referrals for comprehensive assessment of distant metastasis. And the last, Indonesia offers a unique potential for establishing CRC research due to its high cancer burden and diverse cancer behavior. This is the end of my presentation. Thank you for your attention.
Just for a very brief questions, in Indonesia right now, the early onset of colon cancers is going up or going down?
Going up.
Okay, thank you so much. So we're gonna move to the next speaker, please.
Thank you.
Our next speaker is Dr. Thi Hanh Nhu from Vietnam. She is a lecturer in the Division of Gastroenterology at the University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam.
Thank you for your introduction. I'm Dr. Nhu from Vietnam. I'm very honored to join this session, and now I would like to talk about the current updates and future prospects of colorectal cancer in Vietnam. My presentation includes colorectal cancer in Vietnam, colorectal cancer screening in Asia and in Vietnam, research in Vietnam, and future perspectives. In Vietnam, colorectal cancer ranks as the 4th among all cancers in both sexes, with approximately 19,000 new cases in 2022. And the incidence of colorectal cancer in Vietnam is on the rise. And the data show that colorectal cancer incidence has almost doubled in the past 2 decades in Vietnam. Let's move to the colorectal cancer screening in Asia and in Vietnam. About age of screening, the Third Asia Pacific Consensus recommended that there is a rising trend of young patients under 15 years with colorectal cancer in Asia, especially in men and for cancer located in the rectum. However, lowering the age to start colorectal cancer screening to under 15 years has not been proved to be cost-effective in Asia. And in Vietnam, the guidelines for early diagnosis of lower gastric tract cancer this year recommended that colorectal cancer screening in the intermediate risk group should be performed at age 45. And the third Asia Pacific consensus also recommended that risk stratification and sequential offering of tests are reasonable approaches to colorectal cancer screening in Asia. The fecal immunochemical test, FIT test, if positive, the participant will be performed colonoscopy. This risk stratification significantly improves screening uptake and reduces the colonoscopy burden of a screening program. And the consensus also recommended that in countries with rising colorectal cancer incidence but with no organized screening programs yet in place, risk score symptom using simple demographics would be good alternatives to FIT and could help to make the most efficiency use of constrained endoscopy resources. In Vietnam, the population screening program has not been established, and FIT test has also not been available. Therefore, using the simple risk scores should be applied in Vietnam. Among them, the Asia Pacific Colorectal Screening Score, ABSS score, has been developed and demonstrated its performance in stratifying risk for colorectal advanced neoplasia in asymptomatic Asia subjects. And the scores are based on only 4 simple clinical factors, including age, sex, family history, and smoking. And the average risk, if the total score from 0 to 1, the more risk, if the score from 2 and 3, and the high risk if the score from 4 and 7. And a meta-analysis was carried out to examine the performance of ABSS score in stratifying the risk of advanced colorectal neoplasia in Asia Pacific regions. And the results show that compared with the combined average risk and moderate risk group, the high risk group was significantly associated with a higher advanced colorectal neoplasia. And the combination of the ABSS score and FIT substantially improved advanced colorectal neoplasia identification. And now I would like to talk about research in Vietnam. Regarding the early onset colorectal cancer in Vietnamese, and we conducted the study in patients with definite pathology diagnosis of colorectal cancer, and the rate of early onset colorectal cancer under 15 years old were 28%, of which 11% was under 40. Therefore, a high proportion of colorectal cancer in Vietnam appeared at an earlier age than that recommended for screening by the Asia Pacific consensus. And about the ABSS score, and we carry out the study on IBS patients, and the results show that there were 4.7 patients had advanced adenoma, and 2.2% had invasive colorectal cancer. And patients in moderate and high risk group had 5.64 and 12-fold increased rate of advanced neoplasia compared to those in average risk. And in this study, 3 colorectal cancer patients had no alarm features, but high ABSS score. And therefore, the value of alarm feature has a very poor sensitivity for predicting colorectal cancer in IBS patients, followed by our study. And this is the first colorectal cancer screening among about 100,000 individuals was carried out in Vietnam. And this is the results of the study. All participants was performed immunochemical fecal occur blood test, and if the IFOBT positive, the participant was performed colonoscopy, and the results show that the colorectal cancer detection rate among those with IFOBT positive was high at 3.5%. And about the prevalence and risk factor for colorectal neoplasia in asymptomatic Vietnamese undergoing screening colonoscopy, and the results show that the prevalence of overall neoplasia and advanced neoplasias were about 26% and 9%. And this figure shows that the prevalence of overall neoplasia and advanced neoplasia increase with age. And this table shows that the risk factor significantly associated with overall colorectal neoplasia were age equal or over 40, BMI equal or greater 23, and family history of colorectal cancer. Meanwhile, only age equal or over 40 years was the significant risk factor for advanced colorectal neoplasia. And certain serologic lesions are considered precancerous colorectal lesions that should be detected and removed to prevent colorectal cancer. And we carry out the study on about 2,500 patients with lower gastrointestinal symptoms, and the prevalence of SSL was 4.2%. And the risk factor associated with SSL were male, age equal or over 40, hypertension, and diabetes mellitus. And inclusion and future propensity. The incidence of colorectal cancer in Vietnam is on the rise. The age threshold for colorectal screening in Vietnam should be lower than that recommended in the Asia-Pacific region. Non-invasive risk stratification tools such as ABC score should be applied to identify high-risk individuals who should be priorities for screening colonoscopy. Combine the ABC score and FIT should be used to improve advanced colorectal neoplasia risk identification. Despite facing numerous challenges, we hope to develop future effective colorectal cancer screening program tailored to the Vietnamese population. Thank you very much for your attention.
Thank you very much. So I want to be clear, the Asia-Pacific consensus score you are advocating should be a way to target people for colonoscopy. Do you think there's also a need just to use that score to target people for FIT, since you're not doing FIT nationally either, right? You have to still probably target FIT to a population?
So in Vietnam, there has been no FIT test. So in clinical plastic, we train the doctor to do the ABC score. It's very simple score, and if the participants, if the patient was stratified in moderate risk and high risk, and the patient will be performed colonoscopy after that.
So you don't even do FIT, you just do colonoscopy if it's high, the score? I'm trying to understand. So if the score is high, they do colonoscopy or they do FIT?
So if the ABC score with the high risk, and the patient will be performed colonoscopy immediately. Yes.
Okay.
We don't use FIT test in clinical plastics.
So, and that's because it's not available, or, I mean, it seems like you have such a large population that maybe you still probably need an intermediate step, like FIT, before colonoscopy, because as you mentioned, you have limited resources.
You don't have the FIT test, but maybe you have a stool blood test, right? Maybe pretty much the same, so it may be helpful.
Yeah, yes.
Okay, next we're gonna move to the next speakers. I think no need for very much introductions. Justin Lee, Professor Lee is a professor of medicine at University of St. Malaysia. He are world leaders in the gastroenterology, and he just immediate past president of the Malaysia Society of Gastroenterology and Hepatology. Justin, please.
Right, good morning, and thank you again to Ratha-korn for the very kind introduction. I'm just going to say that this is a very important symposium, and Malaysia, along with other countries in the region, is also showing signs of increase in incidence. In fact, a lot have changed for the past 1 decade from number 5th as the most common cancer in the list. Now, in Malaysia, colorectal cancer has risen to the 2nd most common cancer. In fact, among the men, CRC was ranked 3rd after lung and prostate worldwide, but now he has become the number 1 cancer among men in Malaysia. Whereas in women, colorectal cancer ranked 2nd after the breast cancer. So Southeast Asia itself, as many of my colleagues would have alluded to, is probably one of the most populated region in worldwide, with about almost 8.6% of the world total population. We have very distinct culture and ethnicity diversity, but one of the driving force for cancer is probably because of the rapid urbanization driving rapid economic expansion in the region. And also because we have a large population, a rapid economy, there's always would be public health challenges. And when I heard the talk from Indonesia, it will be a nightmare rate to manage 7,000 over islands in that sense. When look at the incidence of colorectal cancer in Southeast Asia, this table illustrates or provides a summary of the incidence of colorectal cancers. And in Malaysia, you can see the incidence is about 6,000. That is approximate to 20 per 100,000 population. And our mortality rate is about 11.2%. These are all the figures for the other countries, at least based on the global the data. So some of the epidemiology facts. In Malaysia itself, we have 3 large ethnic groups, including the Malay, the Chinese, and the Indians. So the highest incidence seems to be found among the Chinese, with about 27 out of 100,000, more than the Malays and the Indian, at approximately 19 and 17.5 per 100,000 respectively. So the incidence rates somehow were higher among the Malays in Singapore. Hopefully, Ting Leong can help to verify this. And these differences among ethnicity may suggest differences in terms of genetic and environmental influences. So many of the Southeast Asia countries, including Malaysia, we do reported higher CRC incidence in older individuals. And I do find a paper indicate that in Indonesia, in fact, 30% of them may be lower than 40 years old. Again, I would definitely hope Dr. Amal can verify this data. In Malaysia itself, we tend to find most cases above 50 years old. But I was talking to Andrew this morning. Our most recent data suggests that those below 50, we have some local data suggesting between 10 to 15%. We definitely have more males, and one of the worst problems that we have is they tend to present very late to the doctors. One of the common ratio that we use is mortality to incidence ratio. This would look at how survival, some differences in response to the healthcare system. And for countries like Brunei and Singapore, they will have a better survival because of their smaller population and better access to healthcare. But somehow, even these 2 countries, they also do report some of the highest rates of colorectal cancer in Southeast Asia. There's also this question about left to right shift. Even in Malaysia, we do have more number of cases in the left colon, but there is a trend showing even the right cancers are beginning to show signs of increase. There is quite a unique question on why left or right distribution of cancers. And one of our most recent research do suggest differences in the gene expression of fibroblast markers. So if you were to look at in this case study, this is something very familiar. The problem is, real world, many of them may have fear of doing colonoscopy. There's a lot of challenges, and these are some of the points to take note of, including compliance, sensitivity of a test, and of course, cost effectiveness. So this is a table that summarizes some of the screening. In fact, in Malaysia, we do not have a national screening program. We have heard from Thailand, from the Lampang studies, Singapore, they do have a screening program. But in Malaysia, it's more of an opportunistic screening. However, we do have some studies suggesting that if you were to do a two-stage, as what many of my colleagues have alluded to, by doing FIT, then colonoscopy, you can see in a study scenario, they do quite well. But in real world, we don't see these kind of numbers. So what are the challenges of screening at least in some of the reported studies in this region? One is the poor awareness, including the risk factors and limited availability of resources and national screening program. In Asia itself, one of the limited or difficulty is the social stigma, the embarrassment, especially among Asian females. We are all very busy with our working life, and very much we don't even bother about doing the screening. And because also many of our patients, they are asymptomatic and no family history. So there is a misconception that Asian patients, they may not get any CRC. Of course, others include the fear, the pain experienced during colonoscopy, and the health damage when you tell them the bad news of cancer. So a multi-center study in the Asia Pacific did conclude that Malaysians is probably the second most ignorant country in the Asia Pacific. And there's also a very poor awareness among our primary care physicians. So in the past, we do not actually have a clear national guideline, but more recently, the government did try to produce some guidelines for our physicians in about 2016 to 2017. We also did institute a national cancer registry to capture some of this epidemiological data, which I think is very vital. Having a national cancer registry is very important to really capture and to audit how we are doing. Of course, one of the reasons why the Malaysian government doesn't or did not decide to go ahead, there are many reasons. One, of course, being expensive, but we do not have also enough endoscopists. And the diagnosis of cancer itself already is causing a significant financial catastrophe to patients. And the lack of government support, policies, lack of third-party reimbursement, issues with liability, all of these are really significant problems in this region. Now, colonoscopy, even though is available in our government setting, in hospitals, but the waiting list can be very long. Some patients will need to wait months before they get a diagnosis, get a colonoscopy, but eventually, once they got it, probably their cancer is already in the advanced stage. So these are some of the studies that I'm personally interested in. I did mention about microplastics being an emerging environmental factors, and I do agree with Andrew. One of the way besides looking at the microplastic itself is to measure the chemical exposure because we know microplastic does compose of polymers and they do carry chemicals. But microplastic, other than being a carrier of chemicals, like I also mentioned, it does carry vectors, something that probably we need to understand, and also it can translocate across the gut and enter into other regions of the body. So at the moment, we are carrying a study looking into role of microplastic in colon cancer. We are taking tissue from the colon and also in the stools. And we also try to understand how this microplastic accumulate and the exposure, what kind of food they come from, and so on. And hopefully, we're able to develop a model on half of it for this particular emerging factors. So the other would be looking into microRNAs. We're also interested in looking into obesity being one of the most important reason for some of our early age or young onset colon cancer. And we have collaboration with our partner universities locally, including University of Malaya, where we look at some of the microRNA signatures in the blood and also in the stools, and hopefully this will help us in personalize more a targeted approach to diagnosis of colon cancer. So with that, I thank you very much and look forward to questions. Thanks.
Thank you so much. We all know that many parts of the world, including ASEAN, even in UK, in US, we don't have enough endoscopists to perform colonoscopy for many of the patients. So right now we have the fit test, yes, maybe available in many countries, and we have a virtual colonoscopy. Have in Malaysia, they perform some virtual colonoscopy for cancer screening?
Now, yeah, we do have stool occult blood tests, we have fit tests, but these are not performed in a nationwide base, but more sporadic, more opportunistic. So most often, when they present to the hospital, they probably get a colonoscopy. The problem is the waiting time. The waiting time is just too long. So despite being opportunistic, we do somehow may miss out the golden opportunity to detect cancers. And I do agree there's a lot of emerging new endoscopy techniques. But again, these are not readily available in the government hospitals.
Yes, Professor Terry, please.
Yeah, I'm glad you identified the problems with the uptake of the FIT testing, because it's unpleasant. And the question is how you increase that uptake. And the UK have put a lot of effort into trying to improve uptake, but it's still, there's 20% plus of the population who will never do it. The way they focused on increasing the uptake is by ensuring repeated follow-up, and it is very labor intensive when people are sent tests, they don't respond to them, then somebody actually goes out and identifies them to encourage that. And I wonder whether there is research in Southeast Asia, and you have a well-organized system in Malaysia compared to some of the other challenges you've mentioned, whether there is research into increasing the uptake and whether there are cultural differences between the Chinese, Malay and the Indian population in Malaysia.
I mean, Simon, that's a very interesting question. In fact, we have identified, from surveys that in general, Asians are more shy, embarrassed, and it's very difficult for them to ask them to provide stools. Indeed. They somehow view providing stools as a very difficult thing, and you are right, without following them up, they would never provide their stools. Yeah. So that is probably one of the challenges, and it will be really useful to identify some of this embarrassment and how to overcome it. I don't think we really address this issue properly, but I do take note of your suggestion.
Because it may be it's just possible that in all these discussions that we have in fora like this, that we're targeting our educational efforts at the wrong people. We're targeting them at sort of us. Maybe we should be looking even at primary school and school children so that you can address that. I mean, that's it. The point is, if you're going to break down cultural differences and resistance, and it's very obvious how unpleasant it is, then you need to get it in at a very early stage before we've fixed our own opinions and our own decisions.
Yes, thank you.
Thank you for the
Thank you very
comments,
much.
please.
Thank you. So our next speaker is Professor Thein Myint from the Myanmar. He is currently the patron at the Myanmar Gastroenterology and Liver Society.
Thank you, Andrew and Ratha-korn, for your kind invitation arrangement. Good morning, everyone. Because of running out of time, I will try to present my presentation as quick as possible. So we have an initial study about colorectal cancer. In the May participants, colorectal cancer is a fifth causes among the cancer. The lung is a first cancer among the male patient. Between female, colorectal cancer is a sixth common causes among the female participants. But according to the global consensus of Myanmar cancer data, in 2018, colorectal cancer is the third common cause of cancer among all the cancer. So previously, it's the fifth and sixth. Now, colorectal cancer is the third common causes of the cancer among the population. Another interesting thing is that colorectal cancer is more common in young people. Like Vietnam, most of the young people, they are less than 40 years age. So mean age is 29.5 years. So males are more common than female. It is quite alarming for us. So age is less than 40. Males are more predominant in young onset, early onset colorectal cancer. So we also did the survey about the clinical presentation of the young colorectal cancer. They usually present with the left-sided colorectal cancer presentation, the tenesmus, bleeding by rectum. Some patients, they present with the mass and abdomen. The few patients, they present with the chain of our habit. So left-sided symptoms is more common in the young colorectal cancer patients. So rectum is the most common site for the young colorectal cancer, followed by retrosigmoid and sigmoid colon. Right-sided colon cancer is little less compared to the left-sided colon cancer lesion. Regarding the stage, so most of the patients, they stayed at the stage 3, followed by stage 2 and stage 4. But recent 2023 data, we can detect early colorectal cancer, but it's less than 2% of our total colorectal cancer. Most of the tumor types are adenocarcinoma, a few patients with GIST, most common neuroendocrine tumor we found at the rectal region, and a few patients lymphoma, non-Hodgkin lymphoma, and very few patients with malignant melanoma. Regarding the screening program in our country, we don't have national program for colorectal cancer screening. We follow the other society guideline. So we do FIT test. Second, FIT test followed by colonoscopy. We don't have virtual colonoscopy practice in our country. Others two DNA tests are not available. In some region, we have to do sigmoid colonoscopy because we don't have enough endoscopists. You may be surprised, in our total population, about 51 million, the endoscopists number is less than 50. It's quite challenging for us to do screening because we are always busy with hematemesis melena, upper GI emergency, and the colo, and other ERCP, EUS, and small bowel pathology. So, as a gastroenterologist, we emphasize with colonoscopy for screening. We try to detect the polyps as much as possible. We follow the proper bowel operation guideline. Now we are practicing the early colorectal cancer detection. In the early stage, we did EMR and ESD. The percentage is less than 2% of colorectal cancer. For palliative, as an endoscopic, we bridging at the end stage colorectal cancer for colonic stenting. In our country, for the management, we practice multidisciplinary team management. I think it's the most important part of colorectal cancer management in my country. So we discuss with the patient family, gastroenterologist, surgeon, oncologist, nurse, dietitian, and nutritionist. Before operation and after operation, we emphasize the nutritional status of the patient. Then we also include a social worker for team management. For prevention, we usually educate the patient and our junior doctor. So we should be ID, weight maintenance to prevent colorectal cancer. So we ask the patient to keep your weight in ID weight and ask the patient to do physical activity, so exercise, and the diet. We educate the patient to take a lot of fiber, fruit, vegetable, and whole grains. We educate the patient, limit the red meat and processed meat, limit the alcohol intake. If possible, we stop. So because of alcohol, not only the colorectal cancer, a lot of harmful effect to our body. And we also educate the patient to stop smoking or reduce your smoking limits. So not only the smoking, because of nicotine, in our country, most of the people, they have the habit of bitter chewing. So we also educate the patient to avoid or quit smoking or bitter chewing. For future, we are interested about the microbiome with colorectal cancer, and then we are also interested the AI technology in our endoscopy field. Now we launched Fuji AI technology for upper GI and lower GI, and Olympus endoscopy for AI for upper and lower GI endoscopy. So in conclusion, CRP incidence in Myanmar is 6.8, is an increasing trend. It's the third common cause of colorectal cancer. Young onset colorectal cancer is increasing. Now we have about 34% of colorectal cancer we found in young patients. So adenocarcinoma is a commonest type. We advise the patient for screening at the age of 45, but we found that our young onset colorectal cancer at the age of 40. So we're trying to detect early colorectal cancer, and we start doing ESG. We are doing multidisciplinary management, and we focus on prevention of colorectal cancer as other countries. So thank you for your attention. Thank you.
Thank you. Questions? Your rate of early onset cancer is very, very high, especially if you are also making that a more stringent definition with age less than 40. Do you think that that's also maybe a reflection of any variation in the likelihood of being diagnosed in the young people versus older people, or maybe less older people getting a full evaluation to diagnose that the cancer is a colon cancer?
So because we can detect the early onset colorectal cancer, in our country, we don't have any national screening program, but patient, there's a symptom and they want to do medical checkup in early age. During medical checkup, we ask the patient to do FIT test so that we can detect the early onset colorectal cancer. Thank you.
So before we're going to close the sessions, Professor Ang, you're from Singapore. Would you please to comment a little bit about colon cancer in Singapore right now?
So I think in Singapore, colorectal cancer is also very important. It's about, I think it's either first or second in terms of the ranking. And we have a national screening program, which is two-tiered, FIT followed by colonoscopy if it's positive. I think similar to what other presenters have mentioned, we do see higher rates of early onset colorectal cancer. But I think because of challenges of resources, challenges of currently people even taking up FIT screening, although they are age 50. So therefore, I think most of focus right now is trying to encourage the pickup rate at the current age rather than lowering the age of screening for average risk adults. Thank you.
Yes, I think that we learned a lot and we can see more information about the colon cancers, not only in the US, but also in many Asian countries. And I believe that this is a good times and an excellent start to set the cooperations between the East and the West to grab more benefit informations to reduce the colon cancer incidence for the young generations in the futures. Thank you so much, and I'd like to thank you for all speakers and participants, and I'd like to say to close the session. Thank you so much.